Good afternoon and welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon. This meeting is being broadcast on Council's YouTube channel, Hillingdon London. My name is Councillor Jane Palmer and I'm co-chair of this board. Before we start, I've got some important housekeeping for everyone present. Could we ensure that our mobile phones on silent, please? We're not expecting a fire drill, so if the fire alarm goes off, please follow officers out of the building. And when you're speaking, could you keep your microphone muted, please, and then unmute to speak. For those of you watching, it's worth noting that some members of this board may be using devices to access the agenda and papers for the meeting. It will mean that they are not looking at anything else on their tablets. So if we can move on to the agenda now, agenda item 1 is apologies for absence.
Chair, we've had apologies for absence from Tony Salmon.
Thank you. Welcome Amanda Kerry McDermott, who has now taken over from Edmund Shan as CEO of Hillingdon GP Confederation. So thank you for being here today. Agenda item, you've done apologies. Agenda item 2 is declarations of interest in matters before this meeting. So other than anything that we've all declared on our register of interest, do any members here have any declaration of interest about what's being discussed? If so, could they state? Thank you very much, which brings us on to agenda item 3, which are the minutes of the meeting on the 10th of June this year. We've all seen them. Do we have any comments on the accuracy of the meeting? Minutes, even? If it's a no, then are these agreed?
Agreed.
Thank you very much. Agenda item 4 is the exclusion of the press and public. If I could just confirm that agenda items... Have you?
Yes, it's 1 to 8 and then 9 to 12.
Oh, that's all right. 1 to 8.
Chair, can I just ask? Apologies, I've just agreed the minutes, but I wasn't at the July meeting. Do you need to find it?
Right, I'm going to take a deep breath and start again. Agenda item 4, I confirm that the items 1 to 8 will be considered in public and 9 to 12 will be considered in private. Whizzing through the agenda, we are now on agenda item 5, which is the Integrated Health and Wellbeing Performance Report and the Service Update. Sean, please.
Thank you. So what I'll do is I'll take us through a brief overview of the Integrated Health and Wellbeing Performance Report with Service Updates. If I summarise as we go through some of the key details within there, if it's okay with everyone, what I'll do is I'll reference slide numbers and page numbers where I can, so if you're looking you can keep track, then maybe take some questions at the end. So starting through with slide 12, page 8, this paper is going to give us a comprehensive update of our progress against the board's key priorities, our place transformation programmes and wider system goals within Hillingdon, with a focus in 3 core areas. The performance against some of our strategic indicators, so we're summarising how we're performing against our agreed metrics, highlighting improvements, and then areas needing further attention to take those forward. Looking at our integrated neighbourhood teams, providing an update on the mobilisation, infrastructure, workforce and governance, outlining some of the next steps within there, and then the reactive care programme, outlining the current status and forward plan, including the launch of the Community Coordination Hub, expansion of the Urgent Community Response, Integrated Rehab and Reablement Service, and then the actions to reduce the no criteria to reside delays. In response to the growing health needs and inequalities, we established as part of this group 5 strategic priorities, which are aligned to our Core 20+5, North West London ICS priorities, HACP strategic plan and obviously the Council's wider policy frameworks. And as a reminder, they are the Start Well, which is improving early years outcomes, reducing childhood obesity, promote school and life readiness. And then we have the Live Well, which is prevent and delay long-term conditions, especially in hypertension, one of the focus areas we have, and then improving mental well-being and strengthen early intervention and carer support through Age and Well, which is scaling proactive frailty management and improving end-of-life care to help people live independently for longer. And then the other two is Healthy Places, which is addressing housing, environment, employment and social isolation, and then Equity and Inclusion, which focuses our resources where inequalities are greatest through the Core 20+5 framework. I suppose as a note, it's just worth saying for the first 2 years, our delivery focus at the moment is primarily on Live Well, Age Well and Equity and Inclusion, ensuring that we're able to balance our ambition with the manageable deliverables, but then some of the other areas are contained with some of the business as usual type areas that we're doing, and we're putting the reporting framework for that as well. So if I move through to kind of slide 13, which is detailed as page 9, this gives us a brief recap of the two key transformation areas we have, and we've designed to meet our strategic priorities. And the focus there would be integrated neighbourhood teams. What we have is we've implemented the 3 co-located multi-agency integrated neighbourhood teams, each with 3 core functions, looking at same-day urgent primary care via neighbourhood super hubs, and reducing demand and primary care and hospital urgent care. Within proactive care, it's for people with severe frailty, using risk stratification and enhanced case management to prevent crisis, and then preventative and anticipatory care for those with mild to moderate hypertension. If we move on to the reactive care side, we are implementing a new borough-wide integrated reactive care service to prevent unnecessary hospital admissions for patients with complex needs and promote rapid recovery after an acute inpatient stay. And included within is a new urgent response service for sudden health or social care deterioration, and an active recovery service to reduce delays across all discharge pathways. I won't highlight some of the key metrics there because we go through some of those but you can see them on the slide. We go through some of how we're delivering against some of those and our next steps to support those. If I move through to slide 14, page 10, there's a high-level sort of progress and outlines some of the key challenges and next steps. So in relation to neighbourhood integration, as I've said, we have all 3 integrated neighbourhood teams are live, which covers us across the borough. 50% of the severe frailty cohort is already case managed, and actually the results from looking after those managed patients, we are delivering about a 36% reduction in non-elective admissions, and we're aiming for the remaining 50% of that cohort to be covered by April 26. In relation to prevention, we have the hypertension prevalence is recorded as 13.8%, which is an increase from 10% earlier in the year, and with 85% of those diagnosed cases under control. The short-term target is to reach 16% by March 26. And other areas we've seen some improvements in the immunisation uptake for flu and COVID due to a few reasons of some provider changes and some targeted outreach work that's been taking place. In relation to reactive care, we have designed and mobilised the reactive care, well, we haven't mobilised yet, but we've designed the mobilisation of the reactive care coordination hub, and that is underway with a anticipated go-live date of December 25. We have the Lighthouse Mental Health Crisis Model has been revised and is due to go live within the next 4 weeks. Then we have some other service, so an example is the Take Home and Settle service was revised and relaunched in July, which is supporting safe discharges, earlier discharges of patients on a P0 pathway. Within hospital flow, we have seen our weekday discharges have improved to an average of 55 per day on average compared to 51 per day the previous month, with modest increase in weekend discharges. However, patients with no criteria to reside do remain high. We have 46 against the target of equal to or less than 34, and that has prompted a system task force to be pulled together with an 8-week delivery plan to deliver that over September and October to support some of those reductions and sustainability going forward. The challenges that we have is actually our ED attendances remain above the target. We're averaging around 196 per day versus a target of 164. Our UTC activity is also above the target, around 189 versus a target of 180. And within our discharge pathway 2, our delays are significant, with about 42% of the patients with no criteria to reside, and averaging around 6.5 days delayed compared to a target of 5 days. And then the last one, probably just the worth, is challenge might be around the estates and the funding constraints, which could be a risk to delaying the super hubs and the full same-day urgent care rollout within there. If I move on to the slide 15, page 11, which highlights the sort of priorities, the progress table, where we are, and actually some of the actions to support some of those going through. If I take them sort of line by line, because they outline where we are. So as I've just said, we have our ED attendances. The target is 164 per day, and we're actually running at about 196. It looks like we have a high demand within there and a limited UCR, which is urgent community response capacity within there. And we have mental health crisis at the front door as some of the key concern causes. The actions that we have include the implementation of the new Lighthouse diversion model, expanding urgent community response, the launching of the coordination hub, and looking into a pilot of mobile diagnostics, all to have a phased rollout from Q3 of 25-26. For UTC attendances, we have a target of less than 180 per day. We are actually at around 189 per day at the moment. Some of the causes are in relation to potential reduction in same-day urgent care funding, and the demand spillover are some of those likely causes within there. We are revising the delivery plan, focuses on stronger front door diversion and capacity management, along with some of the other changes that we have within our proactive and reactive care to support this. Our no criteria to reside, as I've said, is a target of 34. We're actually at 46. We have discharge bottlenecks, referral delays, and family choice are some of the main issues in relation to there. As I've said, we have just pulled an 8-week delivery plan in order to support this and change this as we go through September and October, which is being mobilised at the moment. Non-elective admissions, moderate and severe frailty, our targets are being met or exceeded. This probably reflects some of the effectiveness of the integrated neighbourhood case management and the frailty programmes that have been up and running. Some of the next steps are a full rollout of the severe frailty cohorts to support 100% of those patients. Our unplanned admissions from care homes is just about on target, but it can be variable by care home capability and lack of alternatives for falls and infections remain a challenge. Some of the actions that we have is supporting this. We have a care home champion forum. We have some urgent care plan training, and we are talking about the pilot for access to mobile diagnostics to support care home patients. Within discharge pathway delays under P1, P2 and P3, that's pathway 1, pathway 2 and pathway 3, we have the actions there which will be included within our 8-week delivery plan as we move forward, and then some of the other ones would be some of the further integration of the rehab and reablement service, which we're looking to pull together and commence from January 26 and deliver that further as the year moves on. And then we have our hypertension prevalence and control. Currently we are at 13.8%, and our target of March next year is to be at 16%. Our control is currently at 85% versus a target of 80%, and our outreach is being accelerated to meet the targets within there. I will probably pause there for a minute. The next 4 slides kind of give a bit more detail around some of what I've done, but in the avoidance of trying to avoid duplication, I'll pause and ask for any questions.
Okay, so does anybody have any questions? It's a really, really comprehensive report, isn't it? But I think it does take some understanding. Has anybody got any questions? No. Keith? Oh, sorry. Who was before you? Councillor O'Brien. Councillor O'Brien, do you want to go?
Thank you, Sean. I do apologise. Sorry, my glasses don't do two jobs at the same time. So your name looks like Stan with my glasses on and Sean when they're not. Could I just ask another, with regards to what you were talking about mobile diagnostics within the care home situations, how do you work that out? Do you have to be able to staff that, or is this looking like a real improvement and a way forward to try and keep people in care homes out of hospital? And I have one other question after that one.
Lots of people.
Thank you.
Hello, Councillor O'Brien. So we've been talking to an organisation that actually deliver this mobile diagnostic solution. So it would be in a van or potentially on the back of a bike, motorbike type scenario. And it would include ultrasound, X-ray and potentially some other diagnostics. They're very keen to prove the business case for this, and they also provide a staffed solution. So as well as the equipment, they provide the qualified staff. We'd need to do some administrative logistical coordination, because obviously we need to refer patients into the service, and we need to create pathways potentially directly from the care home into us in the Confederation to actually make that happen. Because if an ambulance is called, then there'll be protocols in place that will essentially mean a person goes to hospital anyway, because they won't redirect. So we need to create a pathway that intervenes to do that. Now, so there will definitely be a cost to that, but we hope the costs will significantly be outweighed by the benefits if the case is proven, and we're looking to do a pilot. Hopefully from before the end of this calendar year, perhaps for 6 months, to be confirmed. But those conversations are quite advanced now.
Thank you. That's quite positive. I mean, if you can keep as many people out of A&E and trying to get around those, that's really positive. And my other question was, and I suppose it's sort of like between, with regards to the hospital versus the lovely adult social care team at home. We were talking about obviously hospital discharge, which is a never-ending process for lots and lots of people. I suppose if I could ask possibly Gavin on your side of it, how are you, what's your experience at this moment in time? Because there's obviously a heavy weight on you. I know your weight is heavy to obviously discharge, but the same with you.
Thank you, Councillor O'Brien. So in essence, it's partnership working. You know, we have regular meetings. Adult social care has daily triage calls with partner agencies planning the discharges. So at both ends, so in terms of planning the discharges, we're proactive, planning for them. In terms of admission avoidance, it's all of that stuff. In terms of the diagnostics, it's our community social work teams and how we feed into that. It's those kind of neighbourhood working elements in terms of, before it becomes an issue, arriving at a solution. So from my perspective, the volumes are high. We've had a very busy summer in terms of hospital discharge, but the only way we can manage that is as a system and working together.
Yeah, just to add to what both Sean and Gavin are saying, in terms of the reactive care support and Amanda actually, in terms of care homes for adult social care, for people and, you know, most importantly our residents, and for the hospital admission process and bed days in the hospital, this is something that we have to take forward. It's vital that people are seen at home with great diagnostics and a real opportunity, and if we can do that in this year, it's a real achievement for the system, for the Health and Wellbeing Board and everybody concerned, to make sure those residents don't get transported to hospital by an ambulance in A&E, spending a lot of time there, not getting the support that they need, and that's not a criticism in any way, but actually they're better off at home. And they will get better care at home. And if we can do that, then that's a real stride forward in our reactive care programme, and absolutely essential that we also look to the pathway that stops us from going direct to LAS, and we work with the providers of all our care settings. And Amanda and I have had some good conversations about telehealth and about how we can support people in the community from stopping needing to go to hospital, because we can do things in the community better for those people than we can do in the urgent care hospital setting.
Keith.
Just a couple of things really. I'm not wanting to pour cold water, but I just want to get a sense of reality check into some of the discussion. So in terms of the care home piece, we get 3 admissions a day from care homes into the hospital, either normally following a fall or chest infections of one way, shape or form. Those nearly all get conveyed to hospital. What's interesting, Professor Goodman sent me a case study only this morning about the impact mobile diagnosis can have in stopping those people having to go to hospital. If they stop having to go to hospital, then we don't have to discharge them. It's a bit of a logic. The bit I just wanted just a bit reality check on is in terms of the no criteria to reside, that's not going to shift doing things the way we currently do it. And I think one of the things we need to do, and the discussions I think we're having at the moment with the place leadership, and I'm meeting Alan on Friday about, is we need to do something radically different to move those numbers, because we've been going at this now for quite some time, and I'm not a great one for action plans, to be honest with you, because they tend not to shift the needle. So I think we do need to think a little bit out of the box in terms of what we have to do here to turn this around. Otherwise, we'll have to be building a hospital many sizes bigger than what it currently is. So it's just to put that on record. But Gavin, myself, and colleagues around the table are having those conversations as we speak, just in terms of doing that, because the numbers don't lie on the page. We are red against 3 of our major requirements here, and I think going back to your challenge a couple of meetings back, Chair, is we need to have adult conversations about how we're going to turn that around. So I think it might be.
I've got Leslie and Professor Goodman waiting, so which one of you wants to go?
Usually I'm told I'm too noisy, so that was good, thank you. And to echo some of that, I think our whole attitude, so your diagnostics will help, but actually, in the main, falls might be the exception, but usually we know somebody's got a chest or urine infection. We don't, to be honest, and we still transport them. So there is something about, and when we know that diagnosis, so great if we get to that. What if we put in place that says actually consistently, we know what the care plan and the ceiling of care, I can't remember what we call them now, but treatment escalation plan is called for that patient, because the number of patients that do come in, and it may only be three a day, but over the course of the year that's quite a lot, that says they do have a treatment escalation plan in place, but actually we still transport them to hospital. So I think that the discussion with LAS, and we've spoken to London about this, that says we need to have a concerted effort on call before convey, because then they can get advice that says don't bring this patient here. We can deploy people to come and treat with antibiotics. And then the other piece of work is, and we would absolutely help with this, which is what work do we need to do with the nursing homes that says actually in this day and age the giving of IV antibiotics is, you've heard me say it here before, is tiddly-pip. So how do we support in terms of going into the nursing homes and making sure that we can do those things if we haven't got particularly nursing homes where they've got trained staff anyway, but how do we do that, and how do we actually train carers to give out? We did it during COVID, so why can't we train carers to give these medications? The way that you do it now is not that difficult. You're not cannulating, you're giving it through a tube, and it isn't very difficult. So I think those very practical steps are the sorts of approach we need in terms of our response to, that says the numbers are big, actually the solutions aren't that difficult, but we've got to mean the solution.
Professor Goodman?
So that works over, because what I'm going to say just builds on what Leslie was saying, is that I've got the London Ambulance data transfers from care homes for this year so far, which is very interesting reading. So In fact, half the transfers are through 111 and other care professionals probably at the care home. So again, that's where pathways are important. A lot of those 111 transfers are probably unnecessary, if not most of them. And then of the rest, just under 50% are breathing problems and falls. And that's the area where, again, the mobile diagnostics can help. And we need to get into mindset, not just the healthcare professionals who work in care homes and 111, but also the local sort of community clinicians to say, actually, not all these patients need admitting with a chest infection, and in fact, an X-ray may help them to say, actually, well, they might have a chest infection, but the X-ray shows it's not that great chest infection. We can give them IV antibiotics if necessary. We can monitor them, and in fact, mobile diagnostics could probably be used for virtual wards as well, because the escalation for that is just 999, which seems a bit ridiculous.
Thank you. Yes. Did you want to go as well?
I just want to ask a very quick question to Professor Goodman.
Go for it.
Thank you, that's really interesting. What I would like, when we're talking about X-ray machines then, with regards to the machines are good enough to be able to see whether an individual has pneumonia or if an individual has a chest infection, because especially in older people, you don't always see face on how deep into the chest issues that they've got. So will they be that specifically able to help?
So the X-ray machines are actually getting better and better with the miniaturisation, and it's always a combination between what the clinical findings are and what the X-ray shows. So we combine both together. So what the X-rays will show you is whether there's any what we call shadowing or fluid, and that determines the sort of extent of the illness. But again, we marry it up with what the clinical findings are. The two must go together. And in many ways, actually, in elderly patients, blood tests are not very useful. They don't pick up everything.
Sandra?
Yeah, just on the care home training point and the staff, and obviously the local authority commissions all of that care and is more than happy to be involved. There are already forums and groups that we can work with, and we would actively encourage them to be part of keeping people in their own homes. So more than happy to start that.
Could I just sneak in? Twice, I think I heard you, if not 3 times, new lighthouse. Can you tell me what's new about it?
Thank you. I can talk about that. You will know from the last time we were here talking about the lighthouse that hadn't seen the numbers increase that we wanted to see in the lighthouse. So as part of a business case that we've put through to North West London ICB, we've got some more money for the lighthouse, which we got confirmation of in the middle of August to say we've got that money. So we'll be looking to enhance the staffing there, and having a slightly different model, which isn't necessarily at the moment. It's more of a kind of bedrooms model. We're looking at having much more of a kind of more like a mental health A&E, where we see more of a kind of flow through of people, and that ideally people will be coming straight into the lighthouse rather than going through the A&E if they don't need to be in A&E. So if they come through the front door, they would be coming straight through to the lighthouse. So that will be up and running. So we wanted 6 weeks really to mobilise the new model, to get the model written up, to get that through our own exec board. So that will be in place at the end of September, 30th of September. We're working towards starting that.
Okay, so if I can go on with this point, because what I remember about it and what I think you've just said is that we don't get people in there. So what is different about that model that is going to encourage people to go there, rather than what we didn't want was a prolonged stay in mental health if a short visit would help? So what I'm not understanding, and what I didn't understand before, is what is the difficulty when the mental health is people experiencing mental health difficulties is on the rise, and I'm not hearing how we're going to get people in through the door. What is different about what this new model is showing, please.
Thanks, Councillor Palmer. Well, in the first instance, if someone's got a mental health crisis, we don't want people coming to A&E if they don't need to be coming to A&E. So ideally, they'd be using one of the other crisis alternatives, like the Retreat and like the Coves, and using the services that we have out there. So that's the first thing that I'll say. And we're doing some work around making sure we're promoting the crisis alternatives. But if people are coming through the front door, coming into A&E, and they're saying they've got a mental health only crisis, of course, if they've got a physical health issue that they're presenting with, they do need to go through A&E. As it stands at the moment, anyone presenting at the front door doesn't have a direct route to the lighthouse. The current model is that they come through A&E, and what's happening there is people are coming in and having to tell their story once, and then actually we kind of call it handoffs, but once you get into A&E, it's really then quite difficult to kind of get out the other side into the lighthouse. And some people might just come into A&E and then go home, but that's not a good experience for them being in A&E, or for people that maybe are around them in A&E as well, and if they're quite disturbed. So the idea is, if people are, we're not wanting to encourage people to come to A&E, but if they do, the idea is that they'd come through the front door. If they don't have a physical health illness, that they would get a kind of quick walk round into the lighthouse. And we've also got people who've used the lighthouse and people who've used our crisis alternative services working with us on this piece of work, so that they can help us identify the best way to let people know about the crisis alternatives, but B, say what is needed when they get into the lighthouse.
Okay, thank you. I mean, it's just a particular bugbear of mine that we do not do enough publicity to the good things that this borough does, and I don't want to see that going down the same way again. So I look forward to seeing the publicity and the linking in with the partners, Hillingdon people. You know, I'm happy to do a video where I talk about it. It's that sort of thing, really. So thank you, Vanessa, that's helpful.
Thank you for your offer, Councillor Palmer.
Any other questions? Sean, do you want to go on with a bit more of it, or you hinted that there may be more that you would like to talk about?
No, I was done. It was just the last sort of 4 slides were greater detail on what I had summarised and gone through. So it just had some of the delivery timelines, a bit more depth behind some of it.
Okay. So it's a very comprehensive report. It's exciting to hear that things, I mean, I'm particularly pleased to hear about mobile visits and things like that. That is absolutely, for me, a really, really good thing to be offering the unwell of this borough. I think that's a really, really good thing to do. Keith.
Yeah, I mean, I agree. We need to be positive about the developments we've got, and at the risk of being as grumpy with this meeting as also chief finance officers last week, one of the things I think we do need to get better at is implementing things. And I think we do great PowerPoints, but we've also got to implement things. So I think the Lighthouse and the IV antibiotics work that we're doing are examples where staff are working very hard, but we're not quite connecting it in a way that we need to connect it. So I just wonder, Jay, rather than being a grumpy old man here, is we look at some lessons learned just to see what we can learn from this and how because these are small implementations of a bigger transformation program that we're having to make. So I think having case studies which sort of say, this is what went well, these are things which we want to avoid, because we don't want to reinvent flat tyres, is the thing I'm worried about us doing. So it's just a thing, I think, if we could bring that forward for future, just some case studies about what went well, what we could learn, I think it would help us moving forward.
Yeah, I think that's a very, very good suggestion. That I think that's what we should be doing. That's how we should be measuring things. I think that's the role of this board, isn't it, really? So if we can all have a think about how we do that. Sean?
I was just going to say, yeah, I suppose, I mean, this report is in development as we move. We set the strategic priorities, and we've set the metrics and the KPIs to measure. I suppose the aim of the report isn't just to show the good, it's to show maybe where we're not meeting as well, so we can collectively work together to improve that. So we have talked about doing some deep dives into some of the implementation areas that we've had around understanding some of those. So happy to kind of keep growing on this format of report. It will keep growing, but then to add in some of those deep dives into the outcomes, because actually if you look at the timelines, and there's a lot of stuff coming, and we want to make sure we learn from what we've done so we can improve as we go forward and meet that as we go.
Yeah, I mean, I'd like to see if it's at all possible some anonymous feedback from residents. You know, if anybody's willing to say this was absolutely fantastic, save me having to go into A&E, that would be really, really great. If there's nothing anybody else wants to say, there is. Leslie, off you go with your mic, please.
Oh, God. Sorry, I've distracted myself now. I'm just thinking, on that point, maybe we should look at a bit of exception reporting that says, you know, why didn't that patient have their IV antibiotics when in their place of safety? Why couldn't that patient go to a lighthouse? And not to be hypercritical, actually, but to say what else would have to be true to make what we all say is our aspiration for us to realise it. So I think we shouldn't be worried, and there are plenty of things when we get to talking about the hospital that the hospital needs to do in terms of exception reporting as well, actually, that says let's use some proper cases that says that really didn't work in a way that we have set up in here. So let's talk about, and that's not necessarily, we can use it as examples here, but that's then for us to work on, that says what was it that stopped that happening. Thank you.
Thank you. So, if we're not going to say anything else about that, what I'm going to propose now is that we move the recommendations in the report, and I think I need a seconder for that, if anybody's prepared to indicate. Thank you, Councillor O'Brien. I didn't see you out the side of my eye there. And are we all in favour of that? We are. Yes. Thank you very much. Which now takes us on to agenda item 6, the community equipment service update. Gary, please.
Thank you, Chair. This item, community equipment service, covers a range of equipment from walking aids, raised toilet seats, to more complex items like hoists and electric profiling beds. It's come to the board's attention because we actually had to replace the provider at short notice due to the liquidation of the contracted provider. We've managed to secure an alternative provider in the form of Mediquip Assistive Technology Limited under a contract which started on the 1st of August. It was necessary for us to introduce a limited service focusing on admission avoidance, discharge support, hospital discharge support, and undertaking repairs of equipment in the community for a short period whilst the new provider built up capacity. We actually put in place a advisory board of professionals nominated across prescribing partners. I'm able to report to the board that we are in a position from this week to move to business as usual, which means that we are still working with a limited number of prescribers, but we will build that up during the remainder of this month. What we've done with the new provider, we've got a contract for 2 years with the option to extend for a further year. During that time, we'll be working on the longer term model, and that should actually give us long enough as well to undertake any procurement activity that's required. I will leave it there, Chair, and happy to take any questions that the board may have.
Yeah, I mean, I just want to say that you know, it's not quite congratulations, but we worked really hard to get this done very, very quickly, and our residents would not have been aware of the difficulties that we were experiencing as a local authority, and of course our partners. This is a market that nobody seems to want to go into, and it surprises me really that we only have a very, very limited group of people that make this as their business. So obviously, as my portfolio, I am aware how difficult this has been, and I would just like to put on record that my thanks to officers Sandra and yourself, who worked really hard to get this done quickly, because it wasn't an easy thing to do, and we've gone back to Mediquip, and other London councils are not so fortunate. We were fortunate because they already came out to this area. So, did you want to say something, Sandra?
Thank you for your thanks. But I would just say this was a whole system response in trying to make sure that everybody got the services that they needed. It's been a very tricky time for everybody concerned nationally, not just Hillingdon as a local authority. So, but I too would like to thank officers that have worked on this, in particular with Sean and Gary and a range of other people, including Jan Major, who have really spent an awful lot of time trying to make sure that this didn't impact day-to-day service delivery. So, thank you.
Yes, thank you. I didn't mean to exclude anyone. My portfolio is quite narrow at times, and but it is also a testament to our partnership working. It doesn't matter which way I look at it. We've done out of a very difficult thing. We've come out of it not too bad for our residents. Does anybody else want to say anything? Otherwise, it is I'm proposing the recommendations in the report, and once again I need a seconder for that. Okay, so noting it is. Are we all in favour of that noting? Thank you very much. Moving on to agenda item 7, which is the pharmaceutical needs assessment. Sheikha, I believe we've got the very comprehensive report in front of us, and we have to see the first page of it on the screen.
Thank you, Chair. Yes, I'm presenting this on behalf of Kim Overy and Kelly O'Neill, who worked on the comprehensive report that you have in your packs. I'll take you through this slide set, presenting a very brief summary of what you have in front of you. So the P&A has been produced on your behalf because every health and wellbeing board has a statutory duty to carry out a pharmaceutical needs assessment every 3 years. The purpose of the P&A is twofold. First one, to provide the health and wellbeing board with a framework for understanding the range and suitability of the local pharmaceutical services in relation to the health need of the local population, and also to support decision-making process while considering applications for new pharmacies. In order to fulfill this purpose, the P&M must link closely to other strategies and needs assessments, primarily to the Joint Local Health and Wellbeing Strategy and the Joint Health Strategic Needs Assessment. The Pharmaceutical Regulations 2013 detail the information required to be contained within a P&A, and the process is specified there as well. So it must include measuring the adequacy of pharmaceutical service under 5 key themes listed here on the left of the slide, and also the types of service providers which are on the right of this slide. I would like to assure the board that the specified processes were followed to assess the current provision and the gaps related to necessary services and other services. And also future needs were considered, i.e. forecasting the need in the next 3 years based on population or policy changes, housing developments, changes in provision of pharmacy services, etc., etc. And a report on the P&A consultation is also included. My apologies. Yes. So, sorry. This slide on methodology, it basically takes you through the key steps. P&A is a well-established process for developing this document, which was undertaken. And in Hillingdon Public Health team and the Business Intelligence team worked together on a project plan. thorough research was undertaken using the available data from various sources like Office for National Statistics data, OHID data. All of that was culminated into determining health need in the current time, and any projections were taken into consideration to predict the future need. And data on accessibility and use of the range of pharmaceutical services was also used to compare that with the need. All of that information is compiled into PNA, which is in front of you, to draw conclusions about what is really needed now and will be required in the future. Those conclusions and analysis were shared with a wide variety of stakeholders as well, as part of the consultation process. And the pharmaceutical services which were included in carrying out the analysis are described here. So essential services which are part of the standard pharmacy contract, advanced services which are additional services that community pharmacists can choose to provide. Enhanced services are commissioned nationally and locally. We can also, i.e. local authority and the local ICBs can also decide to provide some services in their areas, and the examples are on this slide. So these are very brief findings. I'm sure this board has heard about the health needs of the population many times. And just to summarize, the current population is 319,000, is projected to grow to around 342,000 by 2031. And there's variation in population distribution across localities and wards and super output areas. There's greater level of deprivation in the two southern localities. There are pockets of deprivation in the north locality as well, which is considered relatively affluent but has older population. So all of these things are very relevant to what we provide and where we provide, and hence the enhanced services come into play. My apologies, I have difficulty managing slides. Okay, so this slide, that's fine, I think only a few left. Thank you, Sandra. This slide shows location of Hillingdon pharmacies, which are green dots. Red dots are pharmacies in outer boroughs. My apologies, the boundaries lines are not very clear, but you can make out where the long Hillingdon council borders are. Overall, there are 59 community pharmacies in Hillingdon, a rate of 19 per 100,000 residents, which is higher than the England average of 17.7 pharmacies per 100,000 population. Having said that, there is variation in the borough, as you would expect. The rate of pharmacy provision is higher in the north locality, 20.1 per 100,000, compared to the other two localities. Southwest is 18.9 per 100,000, and southeast is 18 per 100,000. Because the localities in the south are more densely populated. There are 55 community pharmacies in Hillingdon which are open for 40 hours per week, 4 pharmacies open for longer. And so this is important because accessibility isn't just about how many pharmacies per 100,000, it's also about the opening hours when people can access. It's also about what services they provide. So it's quite comprehensive exercise and an ongoing task, if I may say, to determine the population needs and provide services. So what we found, moving on to our findings, what we found is that in Hillingdon, 99.7% of the population is within 5-minute drive The most significantly important point in the report, on which I found on page 81, was that a recognition that while the population size does vary between localities, there are differences in factors such as demographic features, health status, distribution of risk factors, morbidity, mortality, which makes health status more complex, and the services, which services we locate in these pharmacies, because of course pharmacists are highly trained NHS professionals who we can use to reduce some of the burden on some of the other services. Based on the narrative regarding age and ethnicity distribution and mortality morbidity, I think we need to look at how we provide services via pharmacies. And lately there have been progress. Pharmacists provide immunizations, smoking station. There has been a history of providing smoking station services, and there are many other public health services that they provide. There was a public questionnaire, as I said, as part of the consultation process, which must take place. There were 166 responses to public consultation, and the top 3 factors that the respondents highlighted influencing the choice of pharmacy were availability of medication, quality of services, and location, which is not a surprise. Most respondents walked to pharmacy with 77% reporting under 15 minutes walk, 18% saying they walk 15 to 30 minutes to access a pharmacy by walk. But again, 99.7% can access pharmacy within 5 minutes drive, and I think 99.9%, if I remember correctly, within 6 minutes drive. There was more feedback from online consultation regarding accessibility from Heathrow villages and amendments to opening times, name changes, etc. for some pharmacies, and all of this is being incorporated as we speak. However, overall, to conclude, there will be variation in the borough level, but broadly, the accessibility in Hillingdon is not bad. In fact, it's better than the overall England situation, availability in the country. There is wide range of pharmaceutical services provided in Hillingdon to meet the needs. No gaps were identified, and work to improve services and ensure a better match between population need and enhanced locally commissioned services will continue. So it doesn't wait for 3 years to be over. Next steps, Chair, for Health and Wellbeing Board to note that work on the 2025 PNA is on track for publication by 1st of October 2025. In fact, it will be on Hillingdon Council website before that. And the final version after this meeting will be prepared for sign-off by Corporate Director, Sandra. And Public Health will maintain an oversight of pharmacy services, including any major changes in the area to closures and concerns regarding access and provision in the area. I will close my presentation with that.
Thank you very much, Sheikha. It's a really, really comprehensive report, and I would like to register thanks to Kelly O'Neill, who's not here to see it, but she should at least be thanked for the work that she's done both for this borough and for this report. Vanessa, you want to comment?
Please, thank you. I agree, it's a really, really helpful and good piece of work. Just linking it to some of the community engagement work that we've done with the Heathrow villages, I just wondered how we could maybe articulate, because obviously some of the work we're doing with the community there is thinking about pharmacy and the gap in pharmacy. I think because 2 out of their 3 pharmacies are actually in the Heathrow airport. And I just wondered if we should probably name that in here, because it links to the work that myself and Keith have been doing with the community engagement piece. So at the moment we're trying to look for somewhere to provide pharmacy, and I just think we probably need to name it if this is our gap analysis.
I think there are services, yes, I think that it is acknowledged that, within Heathrow area, there isn't a pharmacy located, but the pharmaceutical services are accessible, so that needs to be acknowledged as well. So there is Orchard Pharmacy and Village Pharmacy, which provide services to Heathrow villages, collection of prescriptions of GP practices. So authors of this report have done some work in the background, liaising with the pharmacies. We don't advise people in Heathrow villages to drive to Heathrow, but there is delivery of dispensed medicines to housebound people and the elderly. So there are ways of meeting the need, and it is, I think, within 15 minutes drive.
Respond to that.
Yeah, thank you. I think it does say in the report, it does say Heathrow Villages Terminal 3 and Terminal 5 landside, but it's probably just worth us just changing that if that's not correct.
Sure.
I just do think, from my perspective, it's helpful just probably to have a bit of a note to say the work that, so to link this to the community engagement work that we're doing.
Sure.
We can pick it up outside of here in terms of the wording, though.
I just need to understand that and pass on to Kim. Thank you very much, Vanessa.
Keith.
I guess my obvious question is what do we need to do? Is there anything as a result that we need to do differently, just in terms of pharmacy, given the work we're doing in terms of neighbourhood transformation? Are there any key actions that we need to be aware of? Obviously it's a comprehensive report, but there's a so what factor, I think, is what I'm wanting to understand.
Fair point. Sandra, are you answering this or?
Yeah.
Yeah.
Sorry, Leslie, jumping in. Did you want to go? Just to say I agree. I think that there are some points. If you look at the 50% or 50 pharmacies, can't remember which the figure number actually was, are only open 40 hours a week. Frankly, I'm at work longer than that. And how is that accessible? So yes, I agree that we've got short distances to travel to that, but it has to be at a convenient time. So if 40 hours a week is kind of Monday to Friday, if they're open on a Saturday morning, then there's shorter days that they're actually open for. So I think that we probably want really good accessibility, but what I do agree with Sheikah's point and Vanessa's is that there is an awful lot of transportation of medication to the patient, to people's homes nowadays, which is so less visits to the pharmacy are needed. So for me, it's just about understanding, is it really meeting the needs of our residents, which is 166 people responding? Quite clearly, Heathrow residents have always been dissatisfied with the level. It is unrealistic for us to expect them to go into a terminal where they have to pay, etc. And I think it's absolutely right to connect it to the work that Vanessa is doing.
Yeah, absolutely. We've heard long and hard wherever meetings you go about Heathrow, and they do deserve to have it. If we're doing the work, they deserve to see it, because that if we're transparent in what we're doing, it stops the quite correct disgruntled responses that we get, because they just don't see it. And also, if somebody else sees it, it stops people saying that nothing is happening. Professor Goodman, and then Leslie, please.
Yeah, thanks. I think this was a really good and comprehensive report, and it's very reassuring to know that the basic essential services for all residents are being met. However, the whole 10-year plan actually is all about what more we can do, what more bangs we can get for the buck of the NHS. And embedded in here, there's a lot of things that we could do more of. And what's interesting, for instance, is some of the variations of services offered. So if you look at slides 60 to 63, there's a variation in things like flu vaccinations between the north and the southeast, contraceptive consultations, again, between the north, the southeast and the southwest. So all these papers ask sort of demand questions that need to be answered about what can we do to actually maximise that. And what we do know, two things. Firstly, what pharmacists do now is so much different and so much more useful than what they used to do even 5 years ago. And I think we need to have to think about, well, what more can we do for the next 5 years? Can there be some sort of, it may be out of scope for this, but whether we think about a strategic point of things we can do, because there were tables where pharmacists were offered, would they like to do things? And half of them said yes, half of them said no. And again, we need to understand how we could encourage those who said no to actually do things more. And again, how that fits in with a whole neighbourhood, sort of neighbourhood type of approach where everybody's working in one umbrella and using their skills. And the other thing to say is that there are a lot of pharmacists who now work in practices and PCNs as part of the RR staff, and they get trained up to a very high standard, managing chronic diseases as well as medicine management. And again, how we can use those to work with the pharmacies. So this is an excellent study, but I think we can do more with the data and think more strategically about what we can do to help residents.
Yeah, I mean, it's a good point, isn't it? Because if you look at it and see that it ticks all the boxes, it's the right way to go. It shouldn't just stop there. It needs to, what you're saying is my belief too. Let's look forward, because otherwise, I'm not saying it will drop off, but if we don't have the forward plan, yeah. So, Leslie, do you want to come in?
Thank you, and just build on that. So, our most deprived populations have less access to things like flu vaccination and indeed birth control, so those sorts of things, and there is an impact on that. We know that there is. My real point, though, was just thinking about the discussion we had earlier around moving patients, the care of patients into the community and building on that. I suppose there's a question for me, and I honestly don't know the answer to this, which is, so if a GP wants to prescribe IV antibiotics, for example, on a Sunday, where do we get those IV antibiotics? Is it going to be the hospital? So I think that the planning for the future is an easy example, but that planning for the future that says if we're going to change the care pathway, then our pharmacist needs to be able to respond, or we need to have a second order plan that says this is what you would do if you want, your pain control for end of life care or whatever. It goes back to if we really mean that shift of how we're going to look after patients.
Sandra?
Just thinking back to about 3 or 4 meetings ago where we talked about how do we stop people tipping up at the hospital, this is about us surely building on a communication about care in the community and using facilities. Pharmacies are small businesses, aren't they, that if people go to them, they will do more of. And we should be encouraging, but we haven't got that communication strategy, and we talked about it and about how we were saying that that's what we need to do as a board, is promote the services that we've got in the community so that people actually pick them up and use them, and then they'll grow and we've got them available. And that builds on Leslie's point of us then having that accessibility and much more widely available, which is what we need. So it is good, clear report, but it could be so much more, couldn't it?
I think once again I'm going to say exactly the same thing, that I think residents are becoming more aware of what pharmacists do, but I still think there's a very, very long way to go. I was at a meeting recently where I was given a laminated piece of detail about what pharmacists do, and I find that really, really useful and put it in my bag when I go out and see residents, because I do think that a lot of residents just think it's medication and the flu jab. Ian? Sorry, Professor Goodman.
Okay, cool. Yeah.
It's familiar.
Yeah. So 2 things on that. I think probably we could, as GPs, actually put something in our waiting rooms. I mean, most waiting rooms now have TV screens that can flash up things like, do you know your pharmacy can provide this, this, and this? I'm sure many patients don't realise they can get all their contraception from pharmacies. Some do. And I think the other thing, just to mention, I don't know how long, Leslie, but we'll have electronic prescribing from hospitals soon. And that means that patients in outpatients don't have to wait in the outpatient dispensary for a long time, and they'll get straight to their chemists, which means that'll put an extra burden on chemists, and we need to sort of think about how we're going to manage that. So there are all sorts of things for the future we need to think about.
No one will have heard that. Apologies. We are now on agenda item 8, which is the board planner and the future agenda items. So that's just for noting, is it?
Are there any specific items that members of the board particularly want at the next meeting?
Chair, I was going to suggest that we bring the draft health and wellbeing strategy to the December meeting, accompanied with proposals for consultation for the board to consider.
Yeah, I think that's a good idea. Okay, yeah. Have you got a note of that, Nikki, please? Professor Goodman?
We'll know more, so we'll probably do an update with all the changes that are happening at the ICB between North West London and North Central London, and where we are by December.
More of us. Who's... Oh, you! Sorry.
I don't know if this is in the right time of the year, but I picked up within the pharmaceutical report that we've just read about childhood obesity. Just wondering, when can we get it back onto the agenda? I think we've spoken about it in the round for a little while, but would that be possible? Maybe not for this one, but for the next one?
Okay.
Yes, certainly. I think there's a lot of work with the commissioned both adult and child obesity programs at the moment, with some really positive and proactive work going on, and a recent paper has been written around incentives and how that's improving activity. So I think maybe we could bring something for oversight and review of performance at the next board, if that's required.
Oh, definitely. I think Councillor O'Brien's right. I mean, as far as I'm concerned, we've talked about it for quite a long time. I'm not really sure what has improved, and if something has, then we need to see it, because we all need to be going down the right route with that. So go for it, and then
sorry, thank you. Just to say that in that report it did mention the data's quite old. It's 22-23 that was in the report, but the reception years seem to be doing well. We're still 20% above where we should be, above zero, but by the time we get to year 6 again, we're just 40%. So it's still quite stark. There seems to be some learning at reception, and I don't know if that's linked with the work that we're doing with the family hubs exactly, or if that is or something else. So that would be really useful. Thank you very much.
Derval?
Thank you, Councillor Palmer. Given that with 2 of the papers today we've talked about how we communicate with our residents, is it worth us actually bringing something to a future meeting to talk about improving communicating channels, whether it's pharmacies or mental health crisis, or is that better considered outside the meeting and a summary brought back here?
I don't know what Keith thinks, but I think that this is perhaps an unsung board as far as our residents are concerned. I'm not sure who looks at it, who takes on board that we actually do sit here trying to do our best as a united partnership for the health and well-being of our residents. So maybe we do occasionally need to have some sort of feedback as to what we do and how that comes out on a regular basis. I mean, we get it on everything else we do. You can see the reports of what the other committees have done. I don't know, as I say, whether anyone looks at this, but, you know, the Heathrow villages would be a prime example of where we could actually say, we heard what you said, it might have taken us a bit of time, but we've done something about it. And Councillor O'Brien's point about the schools as well. So, yeah. Keith, do you want to comment on that?
So I'd agree, Devon. I think the world's changing, and the requirement that we're putting on our neighbourhoods is to have involvement forums with local residents. And I think the vehicle for doing that, I think bringing someone would be through neighbourhoods, because that's the direction of travel locally. So I think it is worthwhile, and I think it is about engagement, about listening to that. And each neighbourhood will have a different flavour that they want to bring to that discussion. I'm fairly sure. So yes, I think is the answer to that. Whether it's December or a next year one is another issue.
I'd probably suggest next year, but that's just me. We need to be prepared when we start it, is my view. I'm not very keen on starting something when we're not ready for it. Okay, so any other suggestions for the board plan, or otherwise I'll just have that as noted. In which case, then that is the end of the public part of the meeting. Thank you to those members of the public watching on YouTube. Will everyone please remain silent until Democratic Services have confirmed that the live broadcast has ended and the loop has been switched off.